Hello, good afternoon, everyone, and greetings from Venus Medicine Research Center. There's a warm welcome to all our speakers and the audience for being present in today's webinar, Soup to Nuts of Antibiotic Breakpoints. This webinar is a sincere effort to bridge the gap between the microbiological perception and the clinical outlook towards antibiotic sensitivity testing and breakpoints. Before we move forward to the session, let me introduce myself to you. Myself, I'm Dr. Pankaj Mandale, acting as a Senior Director of Medical Affairs for Venus Medicine Research Center. I will be your host and the moderator for today's webinar session. After my welcome speech, the session will be handed to our CEO of VMRC, Mr. Saransh Chaudhary, who will share his views on VMRC, then followed by the session topics by Dr. Camilla Rodrigues.
Good afternoon, ladies and gentlemen. On behalf of VMRC, it is my pleasure to welcome you all to today's webinar on Soup to Nuts of Antibiotic Breakpoints. For those of you who are not familiar with Venus Medicine Research Center or VMRC, please allow me to give a brief introduction. VMRC is the research wing of Venus Remedies Limited and was set up in 2004 with the aim to find innovative solutions to the challenge of AMR. Since our inception, we have worked on a multitude of approaches, including BL-BLI combinations, antibiotic resistance breakers, novel drug delivery techniques, and novel formulation techniques with the singular aim of addressing the unmet medical need of AMR. With a state-of-the-art research facility, VMRC was among the first in India to be accredited by DSIR, obtained GLP accreditations for multiple preclinical labs, and a CPSCA-approved animal house. Over the years, we have added super specialty labs to advance our understanding of bacterial infectious diseases like hollow fiber infection models and, for the first time in India, organ-in-chip models. We have always viewed AMR as a huge public health crisis that needs to be dealt with on an immediate basis and at all levels of the healthcare setup. And the concept of antibiotic breakpoints is critical for the appropriate use of antibiotics in clinical settings. Yet, this remains a highly complex area due to the ever-evolving scientific and regulatory landscape. The content for this webinar was drafted and curated by an expert panel to provide you with a thorough understanding of how to establish and interpret antibiotic breakpoints. Before I leave, I would like to take this opportunity to thank you, all the doctors, the healthcare workers, paramedics, and all support staff who have worked tirelessly over the past year and given their all in the fight against COVID-19. Please accept my heartfelt gratitude. And with that, I would like to hand it over to Dr. Pankaj Mandale to initiate the proceedings for the webinar. Thank you all.
Let us go to the next speaker and a unique presenter, Dr. Camilla Ma'am. Dr. Camilla Ma'am is a consultant microbiologist. She's the chairperson of the Infectious Control Committee in PD Hinduja National Hospital and Medical Research Center in Mumbai. What can I say about ma'am? She is the foundation of the clinical microbiology in India, and she's well known not only in India but internationally as well. She has numerous awards and gold medals under her belt from DC Patel and DC Mehta Award. She has also been awarded at the annual conference of Indian Rheumatism Association and the National Conference on Hospital Infection Control at Indore. She has done an outstanding referee award for the Journal of Association of Physicians of India and also by the Indian Association of Medical Microbiology. Ma'am is also the faculty and external examiner for PhD and DND students, along with numerous lifetime memberships with her, and she has authored for more than 54 publications, both national and international. Dr. Camilla Ma'am's area of interest is in rapid diagnosis of infectious disease, tuberculosis, infection control, newer antimicrobials, and emerging pathogens. So, ma'am, thank you for being here today, and I'm forwarding you the rights for the presentation. Thank you.
Okay, friends, thank you very much. I'm quickly going to go through the conundrums of disk diffusion testing. Yeah, basically, I think all of you know what an antibiogram is. It is an in vitro susceptibility test, and the results are basically lab susceptibility of an isolated strain to different antibiotics. And we all know there are basically two types of antibiograms. One is the hospital antibiogram, which all of us do diligently, periodically take out our AMS reports. And the second is the patient-specific antibiogram, which is what we all look for in terms of defined treatment based on an AST report. Antibiotics, as you all know, are either prophylactic, empiric, or defined. And today we're just going to talk about the defined actual interpretation of the susceptibility reports, particularly the disc diffusion. So you've heard of the AST methodologies are phenotypic, they're detecting biochemical mechanisms, or they even are detection of the resistant genes. Yeah, the next slide, please. And here you have disc diffusion, E-test, as Rahul told you, the BMD and the broth microdilution. And the detection of resistant genes is what we're more or less getting into. I'm actually talking about DST, and as you all know, there are two methods that were approved. One is the Stokes, the Jones-Stokes method, and the Kirby-Bar method. And essentially, the MIC is inversely related to the zone diameter. In other words, the larger the zone diameter, the lower the MIC. And this is just the MIC, which is the lowest concentration, as Rahul has told you, that inhibits visible growth of an organism. And you've seen all of us are now into automated AST testing for MICs because it's just so much easier. But still remember, friends, that we may be automating our MIC methods, but there is still a teeny tiny role for disc diffusion. And this is what actually Aruna spoke about. This is setting and revising breakpoint criteria. And the scattergram of MIC versus inhibition with zone diameters, as you see, the lower the MIC, the larger the zone diameter. So there are actually microbiological breakpoints. Basically, this is almost the ECOF, not exactly, but it's the MIC that distinguishes the wild type from those with acquired resistance. The clinical breakpoint, which is absolutely imperative today, and that is the highest MIC or the lowest zone diameter, giving the maximal efficacy. And there's the PD breakpoint, which is basically the highest MIC where target attainment is more than 90%. So essentially, Rahul has told us that we've been hovering around what defines our clinical breakpoint, and Aruna has nicely told us that essentially it's based on 4 parameters. I think today we've come one step more, that the PK-PD parameters are basically based on Monte Carlo simulation, which is something newer than what it was. And based on the clinical breakpoints, we're now able to distinguish treatable from non-treatable organisms because it's S, I, or R. So basically, the MIC, just to quickly define, because I'm going to use this a lot, the lowest concentration, MIC is a concentration of the patient's isolate that inhibits growth. The MIC breakpoint categorizes the MIC that is S, I, or R, and there are various antibiotics that have different breakpoints, and the MIC of the patient's isolate naturally should be less than the MIC breakpoint. So this is basically a very nice distribution showing the MIC in wild type, E. coli, and Klebsiella. And what we need to remember that isolates with an MIC or zone diameter below the ECOF are always suspect. So in other words, in this chart, if you see where the graphs are, that is basically the ECOFs, and beyond it towards the right side are where the clinical breakpoints are. And you always, which is why the clinical breakpoints that the UCAST has is very, very tight in terms of the relation of the ECOF to the clinical, to the SOR. Okay, so basically look at the breakpoints. The microbiological laboratories have undertaken not only, I mean, this has really proven a huge problem over the last couple of years. When we look at the breakpoints for intravenously used cephalosporins, for Enterobacter, the UCAST versus the CLI. And if you look at the breakpoints, the UCAST says one and the CLSI says another. And that has led to some confusion. There has been a harmonization meeting that has occurred in 2017 to try and bridge the gap. But essentially, it's been acknowledged that the cephalosporin breakpoints used in most European countries fail. This was in 2008, when they actually realized that it was failing to detect the SBLs. So now a lot of water has sort of flown under various bridges, and we are really becoming tight on the MIC breakpoints as well as the zone diameter breakpoints. To be honest, I actually prefer the UCAST breakpoints because I feel they're so tight, especially in relation to the Enterobacter. Okay? So whatever you do, you have to ensure that you use you use a guideline, either it is CLSI or it is UCAST, you cannot mix and match. And that's something all of us have to know. Just because a guideline is not present in CLSI, we cannot take that particular value and apply it to the UCAST. And again, whatever you do, you need to check that the latest updated version of the guidelines is being used. The UCAST 2021 was released on 1st Jan, and the CLSI is just available. Okay, now this actually shows you very clearly, this is a guidance that's taken out of the UCAST breakpoints. And this shows you the difference between the MIC breakpoints and the zone diameters. Now, Rahul did touch on this. Basically, this shows as the UCAST has gone full sort of hog on terms of the I, the intermediate breakpoint. They've called this I, as was being alluded earlier, it is basically no longer I, it is susceptible increased exposure. So here you have, look at agent A. There is no, agent A is here, the antimicrobial agent A. There is no category of I, okay? And when UCAST means I, it means that there is no difference between, say, the zone diameter of S and R, they're the same. Look at agent B, it's I category, and the zone diameter is 23 to 25. So you can actually see there is an I category because they've reported S and R, and whatever is in between is regarded as I. So this table needs at least an hour to explain, so I'm not going to dwell on it, but you can go to the ucast.org. It's a very useful table which tells you how to interpret the various. And I think we all need to take cognizance of this. And what do you do when there are no breakpoints? You just don't report S, I, or R. You report the MIC with a comment saying the MIC is below or above the PK breakpoint, if it's available. Or they're actually allowed, the UCAST has allowed this, that you compare the MIC breakpoint of a closely related organism if possible, especially for the non-fermenters. It is not appropriate to apply disk diffusion or MIC breakpoints that have been borrowed from a table where the organism is not listed. We often try to do that, but that is wrong. So now, since my topic is essentially on disk diffusion, I'm going to tell you why a single MIC may not relate to a single zone diameter. Now look at the MICs that are colored here in this histogram. And if I were to look at the Enterobacteriaceae versus Genta, this is the number of isolators for Genta. You can see an MIC of 2 spans a zone diameter. Look at the MIC of 2, that is here, which spans a zone diameter. This light color is here 2. It spans a zone diameter from 17 to 22. That's not too bad. But if you look at for Pseudomonas aeruginosa versus meropenem, an MIC of 2, that's here, spans a zone diameter ranging from 16 to 34. That's a huge zone. So you can't verbatim from an MIC actually read out, oh, the zone diameter should be approximately this. That is wrong. And this is really a nice article. I think you should read this. This is setting interpretive breakpoints for antimicrobial susceptibility testing using disk diffusion criteria. And basically this shows you that this is the regression lines for tetracyclines you can see here. And the A shows you that this is the MIC interpretive criteria that the lab has done. And if you can see, they've actually tried to, here it is. They've looked at how they've drawn their line of regression, and you can see that these are the possible zone diameters relating to these MICs. But when they plugged in S, I, or R, they got completely different values. And today we believe that translating MIC breakpoints and zone diameters using correlation between MIC and corresponding zone diameters is not really working out too well, because the interpretive rules and breakpoints may vary. Today, more and more, we're coming to realize that we need species-specific regression analysis. And we just can't lump species together. And this was alluded to earlier. This is basically breakpoints for susceptible should never, ever divide the wild type. The wild type is what we alluded to earlier, the ECOS. And so if you have, see here, this is the sensitive bugs and these are the resistant bugs. And if the breakpoint is bisecting this particular curve, you're going to get wrong results. So never, this should not be done. I'm going to just quickly tell you a case, which is really a basic case that happened actually in this patient who lost his life. One, because it was, the report was inadequate, and also the treatment subsequently was inadequate. This was a 50-year-old male who had end-stage renal disease. He came to our hospital with neck pain and quadriparesis and fever for 5 days. You can see he's got lesions in the spine and he's also got a vegetation. Now, when we look at his history, 10 days prior, he was admitted somewhere else with breathlessness, and he was on hemodialysis. He was an end-stage renal disease, so right IJV hemodialysis catheter was inserted, and 4 days later, he developed fever. 2 blood cultures drawn, one through the line and one peripheral, had grown Staph aureus, a humble methicillin-sensitive Staph aureus with a DTP of 1 hour. He improved on ciprofloxacin for 7 days and was discharged. This was his previous history, and 5 days later, like I need to tell you, he came to us with quadriparesis and a vegetation. So, when we looked at the blood culture report in the patient file, this is what was reported. I don't have the actual report, so this was actually typed out. So you can see this was all that the lab had done. They had reported the zone diameter, penicillin looking wonderful, actually resistant, and a whole lot of, there was no interpretive criteria. It was all done on disc diffusion. And this is how the report read. It seemed that ciprofloxacin had a 2+, and for some reason, I don't know why, this patient growing Staph aureus from the blood culture was put on ciproflox. So if you would look at this, what would be most appropriate? To be honest, I wouldn't even look at it. Aruna said, just dump this report. The reasons are this. One, when you, in this particular format, what's wrong, zone diameters plus, 3+, or 2+ are completely erroneous and have no meaning in or of itself. The interpretive breakpoints are derived, like we said, from correlation between the zone diameters and the breakpoints. And if you look at the CLSI guidelines, even 2012 onwards, this is basically penicillin at a zone diameter of 29 is sensitive. So that's pretty huge. And if you look at this is how actually when you do a zone diameter, this is how you would read it. If you can see this is how we actually would, it really is beautiful. When you see the sharp zone, when you're looking at zone diameter here, this sharp zone edge is actually resistant because it's heaped up colonies. Whereas for Staph aureus, when you look at penicillin, benzyl penicillin, you need to have a fuzzy zone diameter like this at the same, almost the same zone diameter. So this is a picture which shows that a fuzzy zone edge is at 26, you report susceptible, whereas sometimes a sharp zone edge, you can see this actually is heaped up colonies could be reported as resistant. And today we all know that Staph penicillinases confer resistance to amox, carbenicillin, and piperacillin, and today almost 90, I would say more than 93% of Staph produce fetal activates. So of course penicillin, regardless of the zone diameter, regardless of what this report had, just on the mere fact that today 95% of Staph are resistant to penicillin, we as clinicians and microbiologists need to make just, calls from a report that may be inadequate. So off goes, when you plug in the breakpoints, you will see that penicillin was resistant at 26, erythro is resistant, clinda we need to talk about, and cipro is really not an appropriate drug for Staph. And if you look at, we all are familiar with the D test, that when erythro is put in close proximity to clindamycin, you can see this straight zone here. So even if there is a zone, this D actually means that this is inducible resistance. And there's a high rate, more than 50% of mutational resistance to clinda, in addition to the inducible resistance. The D test is applied not only to Staph aureus, but also to strep and strep pneumonia. So when you look at more, despite in vitro susceptibility, for Staph aureus that is not oxacillin, that is oxacillin susceptible, that means it's not MRSA, cipro, vanc, and ceftazidime are simply not the preferred drugs for MSSA. So we're actually left with this oxacillin, and an oxacillin disc is actually unreliable, and today we have to use a cefoxitin disc, which is a surrogate for oxacillin, and a zone diameter of more than 22 is susceptible. So when you look at this, is just showing you the zone diameters are different for Staph aureus and different for cons, 22 and 25. In actual fact, instead of giving ciprofloxacin, this patient would have been better off just on clogs. So basically the zone diameters, 3+, 2+, lead to erroneous reporting. penicillin resistant, oxacillin susceptible, or cefoxygen susceptible, are resistant to ampicillin, azlo, and picra. Ceftaz and cipro are not optimal drugs for staph. Clindamycin susceptibility must be validated even if there's a zone, especially if erythro is resistant. And for MSSA, it's clox, much better than a first generation cephalosporin like Reflin or cefazolin, and much, much better than vancomycin. So what went wrong with this case? When he came to us, why did he, on ciprofloxacin, why did he deteriorate so much? And this is the clinical aspects. I was told there are going to be clinicians at this meeting. So why did we lose this patient? Because this patient with Staph aureus bacteremia should have been treated based on that inappropriate report with clox and not cipro. Remember, the clox dose is high. It's 12 grams a day for 6 to 8 weeks. You don't need renal dose modification. Most important, even if we had given him clox, this patient should have had a change of a hemodialysis catheter. And he should have been on a dialysis with a fistula or a port, because the CVC is tunneled, are much higher infections compared to AV fistula or port. And the fourth and most important point is that even a single Staph aureus bacteremia needs evaluation for both the source. In this case, the source was definitely that IJV that was inserted, and metastatic spread. Staph aureus metastasizes to the axial skeleton and to the heart. And as you can see, this poor patient who was inappropriately treated because of the drug susceptibility that wasn't right, and regrettably inappropriately treated by not removing his catheter, and inappropriately treated by not looking at metastatic spread, actually had a bad outcome. So the lab did contribute to a little bit, but so did the clinical management. Why should we worry about Staph aureus bacteremia? Because the frequency of endocarditis is 25 to 32%. And a TEE, a transesophageal echo, should be pursued, especially if there's fever more than 4 days, especially if there's an intracardiac device, spinal infection, and the follow-up blood cultures are still positive after 96 hours. So are we looking in the right places? We know what is susceptible, we know what is I, and we know what is R. I'm not going to go into this. But if you look at this, this is I urge you all to read this reference in JCM. This is basically a point counterpoint differences between the UCAST and the CLSI. And the UCAST actually only has 2 or 3 criteria. They look at S, that was almost the same as I showed on the previous slide. They look at R, and they look at I. And this is what Rahul spoke about. I is the new susceptible. It's no longer regarded as resistant, possibly resistant. It means it's susceptible but increased exposure. And increased exposure basically is a function of how dose, IV or oral, that is the mode of administration, the dosing interval, the infusion time, as well as the PK of the antimicrobial agent influence the infecting organism. So when you have an organism that falls in I, that means as per UCAST, it's a 22 and versus the next R is 24, or S is 24 and R is 22 on zone diameter. It's coming in the range, because there is a 2 millimeter gap, that would come in the range of I, but it means you can definitely treat susceptible but with increased exposure. Now this is the second case. This was meningitis. An alcohol user, 79-year-old man, was found unconscious in the bathroom after having fever and backache. His counts were high, his imaging was normal, and his CSF was a pyogenic picture. He was started empirically on ceftriaxone and vancomycin. Now this was the report that came out. Penicillin, amoxicillin, augmentin, cefazolin sensitive, etc. Remember that as per the CLSI, there is only one beta-lactam that dictates the susceptibility, and that is a disc diffusion oxacillin disc of 1 milligram showing a zone diameter of 16 mm. No other drug is up there in the CLSI. So what should be done in such a case? Would you continue the treatment? Would you change to penicillin? Would you do the MIC, or would you do ceftriaxone? So in this case, it was 16. I wish I could talk to you all, but anyway. So this is the thing. Basically, if it is 20, less than 20, you need to do MIC to penicillin. Okay. And as Aruna told you, for meningitis, the different MICs more than 0.12 is regarded as R, and for pneumonia more than 8 is regarded as R. But I'm telling you that sometimes you cannot do an MIC maybe out far in the, not in a metro. So what would you do then? This is the UCAS guidelines that says that when you use a 1 microgram disc for oxacillin, you can actually use the disc diameter of 8, between 8, if the oxacillin zone diameter is between 8 and 20, you can actually then make judgment calls on whether you want to treat the patient with any of these beta-lactams that are described here. That is, basically ceftriaxone is the treatment of choice. So you can actually you needn't actually do an MIC. Unfortunately for meningitis, you have to. But I'm talking about, say this was a pneumonia or something, you could make do with a disc zone diameter from oxacillin. So this is how it goes. The oxacillin zone diameter more than 22, you don't need to do MICs. If it's less than 20, you need to do an MIC for penicillin. And if it is between 8 and 20, it would be regarded as susceptible to ampicillin, amoxicillin, and a third generation cephalosporin. So for CSF, we prefer to do an MIC to the particular agent we're using, usually ceftriaxone. And in India today, this is a nice article that shows you that the pneumococcal meningitis resistance is quite high. Non-susceptibility to cefotaxime is almost 15%, and to penicillin it is 43%. So the take-home messages are different clinical breakpoints for strep pneumonia, for meningitis and pneumonia, and the disc diffusion criteria exists only for oxacillin and no other beta-lactam. If oxacillin is less than 20, MIC must be done for penicillin. If oxacillin is between more than 8, you can, for non-meningitic infections, just treat on the basis of that with ampicillin, amoxicillin, or even a third generation cephalosporin. And remember, strep pneumonia does not produce beta-lactamase, so adding augmentin will not help. So now let's look at the continued value of disc diffusion for assessing. This is also a very nice article written by Romney, which says that it was actually what we were doing for so many years. But today, for a variety of reasons that I'll dwell on in a couple of minutes, they've sort of lost favor. So many laboratories are reluctant to implement disc diffusion for a variety of reasons, including dwindling proficiency with this method. Most people are not really comfortable doing this. Interruptions of the lab workflow. There's uncertainty surrounding the quality and reliability of disc diffusion. And most important, a perceived need that we must report MICs to clinicians. Let me tell you, an excellently done disc diffusion is possibly better than a badly done MIC. For MIC is sometimes the only methodology for AST. In these situations, there are no disc diffusion criteria. MIC is absolutely a must for colistin and Enterobacteriaceae. They are disc diffusion criteria for pseudo. But for colistin, for Enterobacteriaceae and Acinetobacter, there are no disc diffusion criteria. Why is that? The reason is that colistin is such a hugely large molecule, you just can't do a disc diffusion rightly with it. Similarly, Vanco and Adapter for Staph aureus, Levo for Burkholderia cepacia, you have to do a MIC for meningitis if the oxacillin zone diameter is less than 20, as I just discussed. Similarly, BGS for sterile sites, you need to do an MIC. Anticar, Clav, or Septas for Stenotrophomonas maltophilia. And some situations, because MIC is tighter, in endocarditis, meningitis, sepsis, and really sick patients, an MIC is definitely advised. And sometimes when the patient is not responding despite an S on a disc diffusion. This is a publication that was just published, which talks about disc diffusion criteria being disc diffusion directly being applied from blood cultures that flag positive. And this is a UCAS study that said it's pretty good actually. If you directly, when a blood culture flags positive, you may want to bat on from the blood culture bottle, do a disc diffusion test. And this the US is also doing. They're also looking, as of Jan 13th, they've looked at so many antibiotics for disc diffusion, bat on from direct disc diffusion from a blood culture. This is going to be wound up in a couple of months. So you will have zone diameters or disc diffusion from blood culture directly. So why are we so against this diffusion? Why did it get a bad name? So we don't have to hang the disk diffusion. The reasons are that standardized AST, the results change with change parameters. It's absolutely crucial to adhere to methodology. Standardization of potency of antimicrobials, standardization of types of media and supplements, standardization of inoculum, incubation and reading of results is absolutely paramount. Transmitted light versus reflected light, all these play a huge role. This was a reference that was published just last year. The UCAS evaluation of 21 brands of Muller Hinton, and they found it was all over the place. So these are the reasons why perhaps this diffusion is losing favor, because if you are not going to get this Muller Hinton from, say, the very best, you may land up in erratic results, because they evaluated the performance of 21 dehydrated Muller Hinton and just 6 met the criteria of being really good. Now, there's another issue that you need to that is known as ATU. That's basically of technical uncertainty. So let's look at this piperacillin tazobactam of a zone with an MIC or a zone diameter, MIC of less than 8 and a resistance more than 16, and a zone diameter of 20 and resistance less than 17. In this situation, they've not called it intermediate because pip-tazo in enterobacterials is a huge issue. The reasons are that, especially now with ESBLs, I don't know if you are familiar with the Merino trial that actually proposed that ESBLs did fine with BLBLIs. But the post hoc analysis that was done subsequently actually showed no. Pip-tazo, when it was an OXA1, when it was had an OXA1, you needed to have it really had a high MIC, and pip-tazo was not associated with very favorable outcome. So when you get an ATU of discs on this disc zone from 17 to 19, you need to think of what you're going to do. You need to either do an alternate method, repeat MIC, or do a genotypic test, and sometimes you need to downgrade your result if alternatives are available. The other sources of errors in disc diffusion are incorrect disc potency, incorrect handling and storage. In India, let me tell you, there are such huge problems you have. Even when you use a meropenem disc, even in my lab, when the technicians take it out early in the morning, if they're doing a disc diffusion, when we were doing it, they'd take out all the discs, they would plot it all, and let me tell you, meropenem disc becomes unstable if it's kept outside 4 degrees for more than 4 hours. So you're using an inappropriate disc if you don't finish that cartridge. Similarly, the disc quality, the quality of the agar base, supplements, cations in the media, excessive cation content actually reduces the zone sizes, whereas low cation can increase the zones. pH, if the pH is too low, aminoglycosides, fluoroquinolones appear to lose potency. What about the agar depth and excess humidity? This is just a slide to show you how excess humidity completely messes up your zone diameters. So you must remember that we have to have dry plates. You have to have either the plate should be kept, well in advance of actually doing the test and dried before you inoculate your plates. And this is reading of disc zones. As you can see, this is Enterobacterialis E. coli for phosphomycin. And look at this. A, B, and C are seemingly, you'd want to just say these are R, but actually for phosphomycin, these are S, because you can actually read the outer zone. This is one of the peculiarities of phosphomycin, and only this one would be regarded as R. Similarly, Stenotrophomonas, when you did only this criteria are available on UCAST with TMP SMX, A, B, and C can still be susceptible, and it's only D that would be resistant. And this is again from the UCAST. This is again Enterococcus with vancomycin. Remember, you can't do Staph aureus with vancomycin, but Enterococcus can be done with vancomycin. And you can see A, sharp zone diameter more than 12 millimeters reported as susceptible, whereas B, C, and D are reported as resistant. This is another huge problem with the disc diffusion testing. And this was a study that was done on the quality of the antimicrobial discs from 9 manufacturers. To be honest, there were 9, and they did one in 2014. They told them we're going to do another one in 2017. This was published in CMI. And only 1 or 2 actually came out green. The ones that are red and yellow have some issues. But it's really tough to actually look at the variability in disc quality over time. And this means internal QC is vital. This is another really good reference which talks about how you would ensure high quality discs. It's too long to go into this, but every one of these definitions needs to be adhered to when you're using disc diffusion for your discs. Okay? And again, when you're actually looking at the QC, you look at the range. You have a range and you have a target, and this is how it's defined for your control strains. And this is how you would monitor your QC. This looks, looking okay. It's looking fine, but actually, if you analyze it, the trend actually shows that this started showing a single result outside the control. You sort of said, let me look at it the next day. But then subsequently, you started getting a lot. The results are within limits, but on the lower side. So these, again, warrant checking, and they could reflect on your patients. So finally, friends, the challenges in AST are really, we need to remember that changes in breakpoints over time may not reflect new understanding or appearance of new resistant determinants. Inappropriately set breakpoints, that's happening all the time. And regional differences in susceptibility breakpoints may hugely impact our antimicrobial susceptibility testing. Thank you. This incidentally won an award. This is a nice cultures on a agar plate